Hello everyone, this is my fifth video on neonatal resuscitation. Today I am going to cover the last part of NR, in which I will tell you about what are the medications indicated in NR, some special considerations, and how to resuscitate the preterms baby, and some ethics and what will be the care we have to provide at the end of life. So this is the step D, drugs. So when the patient, after doing all these steps of NR, as I have already explained how to perform the initial steps of resuscitation, how to provide the positive pressure ventilation, and how to give the chest compression. If the patient is having during evaluation heart rate less than 60 beat per minute in spite of full 1 minute chest compression with tube and bag ventilation, then we have to insert the UVC and give the IV epinephrine, and we can repeat every 3 to 5 minutes if the heart rate remain less than 60 beat per minute. Also we have to consider that patient may be having the hypovolemic shock. So we should give the fluid for the hypovolemia. And also we should keep in mind that patient may be having the pneumothorax. So go for the X-ray and rule out the pneumothorax. So if the heart rate is not improving in spite of chest compression with positive pressure ventilation, then insert the umbilical venous catheter. In this image you can see UVC inserted and give the IV epinephrine. What will be the indication of adrenaline if heart rate remains less than 60 per minute even after 60 seconds of coordinated chest compression and effective ventilation? What will be the mechanism of action of the adrenaline? It will increase the systemic vascular resistance. It increase the coronary artery perfusion pressure. It improve the blood flow to myocardium and also restores the depleted ATP. How to administer the adrenaline? We can give IV, which is the preferred method. If not possible to insert the UVC or IV cannula, then we can also give the endotracheally. So the preferred route is intravenous. Now how to prepare the pre-filled adrenaline syringe. Whenever we are checking the instrument before the birth of the baby, we should prepare the adrenaline syringe. So we have to take the 1 ml of the adrenaline and dilute it with 9 ml normal saline. So in ampule concentration is 1 milligram per ml, 1 is to 1000 concentration. When we are diluting 1 ml adrenaline with 9 ml normal saline, then it is 1 is to 10,000 solution which contain 100 microgram or zero point 0.1 milligram adrenaline in 1 ml. So we have to prepare this syringe before the birth of the baby. So here in this image you can see this is pre-filled syringe and this is the adrenaline ampule. Now the dose of the adrenaline IV we can give 0.1 to 0.3 ml per kg of 1:9 diluted adrenaline. In microgram 10 to 30 microgram per kilogram. In milligram 0.01 to 0.03 milligram per kilogram. And the trick for the IV dose of 0.01 milligram per kilogram is weight into 0.1. So for the 3 kg baby we have to give the 0.3 ml. For 2 kg baby 0.2 ml. Endotracheally, we can give 0.5 to 1 ml per kg or 50 to 100 microgram per kilogram or 0.05 to 0.1 milligram per kilogram endotracheal dose. We should give rapidly as quickly as possible. We can repeat the same dose after every 3 to 5 minutes if it is required. In the form of MCQ, this can be asked, what is the preferred concentration of epinephrine for newborn? So the answer is 0.1 milligram per kilogram. That's why we have to dilute the 1 ml adrenaline with 9 ml normal saline. What is the initial dose of epinephrine in newborn? 0.02 milligram per kilogram. If the baby's heart rate less than 60 beats per minute, then we can repeat the dose of epinephrine after every 3 to 5 minutes. If the patient is having hypovolemia, then we can give the volume expander. Normal saline is the preferred one. If not available, then we can give the ringalactate. And the dose is 10 ml per kg over a period of 5 to 10 minutes. And the preferred route is umbilical venous catheter. Rapid infusion in less than 30 weeks gestation age baby can lead to the intraventricular hemorrhage. In case of preterms newborn, some additional resources, some additional persons will be required, some additional thermoregulatory strategies will be needed. So example, portable warming pad, polyethylene plastic wrap, pre-warm transport incubator. And when we are giving the positive pressure ventilation, we should keep in mind that PIP should be only of 20 to 25 centimeter of water, not more than this. Otherwise, preterms newborn will develop the pneumothorax. We should also consider the prophylactic CPAP, prophylactic surfactant. Now, once the baby is having the heart rate more than 100 beats per minute and also spontaneous respiration started, then about the post resuscitation care, and we should also do the team debriefing. So in the post resuscitation care, we should avoid the hyperthermia in severe birth asphyxia newborn. We should consider the therapeutic hypothermia if it is available within 6 hours of birth in full terms. Babies with the severe birth asphyxia having the HI, hypoxic ischemic encephalopathy. We should also monitor for the apnea, bradycardia, BP, SpO2 and urine output monitoring should be done. We should monitor the blood sugar, electrolyte, hematocrit, platelet, ABG in such a patient. We should maintain the adequate oxygenation and support the ventilation as needed. During post-resuscitation part, we should delay the feeds, start the IV fluids and consider the parenteral nutrition. Consider the inotropes and fluid bolus for shock. Ensure the adequate ventilation before giving the soda bicarb. Soda bicarb is indicated only in severe metabolic acidosis, which is generally seen after severe birth asphyxia and also in the patients of meconium aspiration syndromes. Some special consideration. Example, if the patient is having laryngeal wave, cystic hygroma, congenital goiter, in such a case, early intubation and tracheostomy may be required. If pneumothorax, then percutaneous needle insertion should be done in second intercostal space in mid-clavicular line, and ICD insertion should also be done. If pleural effusion, then ICD insertion. In congenital diaphragmatic hernia, urgent surgery should be done. So such special consideration should be in mind. Some of the ethical issue we should keep in mind, that if baby's birth weight is less than 400 gram, maturity is less than 23 weeks gestation, or baby is having the major congenital malformation in which we know the early deaths can occur, and even we know the if the patient will survive, patient will have the unacceptably high morbidity. In such a case, we should explain to the parents that in spite of doing all these things, patient either die early or if survive then will have the very high morbidity. And all the things we should document also. After 10 minutes of continuous and adequate resuscitation, we can discontinue the resuscitation if patient is not showing any signs of life even after 10 minutes of continuous and adequate resuscitation. No heartbeat, no respiratory efforts. In such a case, we can discontinue the resuscitation after 10 minutes. So this is all about the neonatal resuscitation. I have covered all the parts A, B, C, D. Thank you so much.